For this video, we will be continuing with our discussion of diabetes, but now we will shift our focus to type 2 diabetes. So we will not go over the normal physiologic mechanism of insulin secretion and signaling, so if you need a quick refresher, I would recommend revisiting the first few slides of the type 1 diabetes video linked for the first IQ case this week. So now let's dive into the pathophys behind type 2 diabetes. So now type 2 diabetes begins with a number of genetic and environmental factors leading to some degree of insulin resistance at the target tissues, like the hepatic, adipose, and muscle tissue. So because of this insulin resistance, the normal amount of insulin released has a much more difficult time activating its respective receptors to trigger that GLUT4 insertion and downstream glucose utilization, as well as other insulin-related effects, because the targets are just less responsive. This reduced glucose utilization would usually result in hyperglycemia, but early on in type 2 diabetes, the beta cells are able to compensate and overcome this insulin resistance by secreting more insulin than usual to force that glucose inside of the cell, maintaining normal glycemia and overcoming that insulin resistance. So moving to the next slide. However, this amped up insulin secretion by the beta cells is not sustainable and eventually leads to beta cell burnout and an inability of the beta cells to secrete enough insulin to maintain normal blood glucose levels. This is going to lead to a relative insulin deficiency and hyperglycemia, and all of those same signs and symptoms of diabetes like polyuria, polydipsia, and an elevated A1C, and a diagnosis of type 2 diabetes. So moving on to our next slide. Now, as type 2 diabetes progresses, this prolonged hyperglycemia is toxic to beta cells. And this, along with other physiologic changes we won't focus on in this video, can eventually, over many, many years, lead to the apoptosis of pancreatic beta cells and eventually that absolute insulin deficiency. So no more insulin production, as well as a number of macrovascular and microvascular complications along the way. And determining if a type 2 diabetic has a relative versus an absolute insulin deficiency will be important for therapeutic selection, which we will discuss a little more later on. Now, in the next few slides, we will discuss different agents and classes of agents that are indicated for the treatment of type 2 diabetes, and the primary focus will be on mechanism of action, but I will try to mention their place in therapy. For example, if it's a first-line, last-line agent, or for a specific group of patients. And I will mention some of the key characteristics that you can use to group these agents. So for instance, A1C reduction potential, risk of hypoglycemia, potential for weight change, etc. And keep in mind, many type 2 diabetic patients will likely be on multiple agents. So these characteristics are a good way to compare agents to see what makes sense to combine and what doesn't. So moving to our next slide. We are first going to discuss agents that fall into this group called the insulin secretagogues, which include two drug classes, the sulfonylureas and the meglitinides, both of which stimulate pancreatic beta cells to release insulin. And a lot of times patients will refer to these as their insulin-releasing pills. We will start off with the sulfonylureas. And these would be agents like glimepiride, glipizide, and glyburide. And these agents are second-generation sulfonylureas, and these are really the only ones that we use today, all of which are going to end in IDE. So these agents act by binding the sulfonylurea receptor on the ATP-gated potassium channels on the beta cells. And this inhibits the channel so that we have that same buildup of potassium ions and depolarization to trigger that calcium influx and that insulin release, just like we would see with the influx of glucose. So once released, that insulin can then trigger its signaling cascade, leading to that reduction in blood glucose levels. So these agents lead to prolonged effects despite their half-lives being pretty short, which is why it is really important to counsel patients on maintaining a meal schedule and not skipping meals, because these agents will trigger insulin release that is prolonged regardless of blood glucose levels. And I'm sure you can guess that hypoglycemia is the primary adverse drug reaction we are concerned about with these agents. One of the other things to mention is because insulin is an anabolic hormone, it can lead to weight gain. So the fact that these agents are triggering insulin release means that there is a risk of weight gain with these agents. So setting appropriate patient expectations is important. So these drugs have been around for a long time, so they are pretty cheap and can provide a good 1 to 2% reduction in A1C. Now we will shift our focus onto the non-sulfonylurea secretagogues, being the meglitinides. And this group of agents include repaglinide and etaglinide. And this group of agents will all end in the glinide ending, and they actually work in a very similar mechanism of action as the sulfonylureas. So by binding the sulfonylurea receptor. But what is unique is that their effects are actually glucose dependent, meaning that the level of insulin released triggered by these agents is sort of proportional to the blood glucose level. So there is less risk of hypoglycemia. Also, because less insulin is released, there is less of a risk for weight gain. But this also means there's going to be less A1C lowering potential at around less than 1% reductions in A1C observed. Now, shifting gears just briefly, so remember how I said the selection of certain agents will depend upon whether the patient is in a state of relative or absolute insulin deficiency. Well, these secretagogues depend upon the pancreatic beta cells being able to produce insulin. But if the patient has an absolute insulin deficiency from the prolonged hyperglycemia killing off the beta cells, resulting in, for instance, a low or no C-peptide value, for instance, then these agents will not work. So this is one key point to keep in mind with agent selection. And now this brings me to exogenous insulin administration, which is an option in type 2 diabetes, but just usually not the first option unless their A1C is very high to start, and this is usually reserved as an add-on once several oral agents have been tried and combined, and the patient is still not at A1C goal, or once the patient progresses to a suspected absolute insulin deficiency. So usually basal insulin is added first to other agents, and then mealtime insulin if needed later on. And I won't go over all the different types again, but if you need a refresher, revisit the type 1 diabetes video. So things to keep in mind is there really isn't a cap on A1C lowering potential, but we have those risks again of weight gain and hypoglycemia like we discussed with the secretagogues. So moving on to the next slide. So now that we have covered the secretagogues and insulin in type 2 diabetes, we are going to transition to our insulin sensitizers, which are metformin and the drug class known as thiazolidinediones, or TZDs. So moving to the next slide. We will start with metformin, which is one of the first-line options and very common unless there is a compelling indication like renal disease, cardiovascular disease or risk, or obesity that may cause you to choose another agent. And you will see this one often because in addition to its very low cost and its ability to lower A1C by about 1.5%, and has also been shown to reduce overall mortality associated with type 2 diabetes. So metformin leads to a number of downstream effects that start with it entering the target cell and then activating AMP dependent protein kinase, which can then help promote this cascade to translocation, glucose uptake by the target cells, and that downstream glucose utilization, leading to improved insulin sensitivity at the target cells and a number of metabolic changes. One of the main ones is turning off hepatic glucose production. So in the insulin-resistant state of type 2 diabetes, the body thinks it needs more glucose because not enough glucose is getting into the target cells. And this is going to trigger that hepatic glucose production, which adds to the already elevated blood glucose, which still can't be used. So the insulin sensitization promoted by metformin allows that glucose to enter the cells, turning off that hepatic glucose production, which is thought to be the biggest contribution to blood glucose lowering with metformin. Because of its mechanism of action, it really is just working in the background and doesn't directly lead to insulin release. So minimal concern for hypoglycemia with this agent, as well as weight changes. If anything, patients may experience weight loss. The GI side effects are actually the most notable adverse drug reactions for this agent. So starting low and titrating slow to target doses and taking with food is very important. This agent is also renally cleared, and rarely this agent can lead to lactic acidosis and an acute kidney injury or AKI. But just in summary for metformin, it is very cheap, very effective, and it is first line, so it's very common. Our next agents we're going to discuss are our thiazolidinediones, or our TZDs, being pioglitazone or rosiglitazone. And notice they all end in this glitazone ending. And these work through a different mechanism to lead to insulin sensitization. So these agents actually bind and activate the PPAR gamma receptor in target cells, which is a key transcription factor that leads to the expression of genes that regulate glucose and lipid metabolism. The downstream effects leads to improved insulin sensitivity at target tissues. So more GLUT4, more glucose uptake, reducing blood glucose levels, and again, we are turning off that hepatic glucose production. So the TZDs can lead to a 0.5 to 1.4% reduction in A1C. However, they do come with several important things to consider. Importantly, these agents are contraindicated in symptomatic heart failure because they can lead to fluid retention, which may lead to a heart failure exacerbation. There is also a risk of weight gain with these agents. However, like metformin, that risk of hypoglycemia is less compared to some of the other agents like the secretagogues. So moving to the next slide. Now this concludes our discussion of insulin sensitizers. So now we can switch gears to incretin-based agents. So incretins are a group of metabolic hormones that stimulate a decrease in blood glucose levels. So incretins are released after eating and augment the secretion of insulin from pancreatic beta cells in a glucose-dependent manner. So some refer to incretins as insulin helpers, and the main one we will be discussing is GLP-1 or glucagon-like peptide 1, which is produced by the L cells in the ileum shortly after a meal. So the released GLP-1 will bind its receptor on pancreatic beta cells to promote insulin secretion and lower blood glucose. So GLP-1 also delays gastric emptying time and promotes satiety, which we'll come back to in a second. And once the effects of GLP-1 are no longer needed, GLP-1 is inactivated by dipeptidyl peptidase 4 or DPP4, again, inactivating GLP-1 so that its effects are not prolonged. So in order to exploit this incretin-based mechanism therapeutically, two different classes of agents were developed. The first we will talk about are the GLP-1 receptor agonists. Some examples of these are liraglutide and dulaglutide. And the third one, which I'm not going to write for sake of space, is semaglutide, which you have likely seen commercials for these three, which are Victoza, Trulicity, and Ozempic. So these agents are almost homologous with endogenous GLP-1, and the primary difference between the two is that the GLP-1 receptor agonists have minor structural changes incorporated that make these agents more resistant to DPP4 cleavage and inactivation. So essentially, they have a longer half-life and stick around in the blood longer. So these agents will lead to about a 0.5 to 1% reduction in A1C and have been shown to reduce the risk of atherosclerotic cardiovascular disease-related events. And they promote weight loss. Due to that delayed gastric emptying time and the promotion of satiety. So these agents also have minimal risk of hypoglycemia, unless they are combined with insulin or secretagogues. So the downsides of these agents is that because they are a protein, they must be given sub-Q. Otherwise, the harsh stomach environment would destroy them, and they are newer, so they are also much more expensive. Unfortunately, because we are supplementing a hormone, which is usually tightly regulated, this agent does come with a black box warning for medullary thyroid cancer and multiple endocrine neoplasia syndrome. So patients need to be counseled on signs and symptoms of thyroid cancer, for instance. The main side effects are nausea, vomiting, and diarrhea, and there is some risk of acute pancreatitis. So there are a number of benefits that come with these agents, but lots of patient factors to consider first. But this is going to be one of our first-line options, especially with obesity and cardiovascular risk or disease. And then one other agent I do want to mention on this slide is tirzepatide or Mounjaro, which has this GLP-1 receptor agonist activity and also GIP agonist activity. And we're going to discuss this agent in more depth for obesity in block 3, but it can be used for type 2 diabetes, so I did want to just mention that here. The next group of agents we're going to talk about are the DPP4 inhibitors, which act just as you would expect in that they inhibit DPP4 so that endogenous GLP-1 that's released hangs around for longer to promote its beneficial effects. So these agents like sitagliptin and others, all that will end in this gliptin ending. And these agents, just like the GLP-1 receptor agonists, have a low risk of hypoglycemia. They are given orally, but they can be pretty expensive. They also don't lead to a lot of weight change, and they really only lower the A1C about 0.6 to 0.8%. And they do come with a risk of pancreatitis and arthralgia, which may be severe enough to require discontinuation. So moving to the next slide. So now there are only 2 more groups of agents left that we need to cover, and that will conclude our discussion of the type 2 diabetes treatment options. So moving on to our next slide. So our first group that doesn't fit into the previous category and that aren't really used much anymore, but in case you do come across them, are the alpha glucosidase inhibitors, like acarbose and miglitol. So in the intestinal brush border, the enzyme alpha-glucosidase is responsible for the hydrolysis of complex carbs into oligosaccharides and eventually glucose, which can be absorbed to enter the systemic circulation. The alpha-glucosidase inhibitors act to competitively and reversibly inhibit the alpha-glucosidase enzymes to prevent the breakdown of these carbs into absorbable products. And since they cannot be absorbed, the glucose that would normally be absorbed can't contribute to the hyperglycemia. And this ends up leading to about a 0.5% A1C reduction. Now, as I mentioned, these aren't used much anymore because we now have more effective agents, and because of the complex carbs never being broken down, this leads to dose-limiting GI side effects. So our next group has gained a lot of favor despite it being one of the newest agents for the treatment of type 2 diabetes, and these are the SGLT2 inhibitors, or the sodium glucose cotransporter 2 inhibitors. And these are going to be agents like dapagliflozin or empagliflozin, and you have likely watched commercials for these, like for Farxiga or Jardiance. Now, I know you have yet to have renal, so do not focus on the renal physiology here, but in the kidney, glucose is freely filtered from the systemic circulation into the urinary filtrate of the renal tubules, but almost all of the glucose that is filtered from the blood is actually reabsorbed from the filtrate and back into the systemic circulation. And one point that will be helpful later on is that water always follows the solutes in the renal tubules. And the main transporter that's responsible for the transport and reabsorption of glucose is the SGLT2 transporter, which is found in this proximal region of the renal tubule. So by inhibiting this transporter with our SGLT2 inhibitors, glucose cannot be reabsorbed back into the bloodstream to contribute to the elevated blood glucose, and instead remains in the urinary filtrate to be excreted from the body. And this also leads to diuresis because water will follow the glucose instead of being reabsorbed. So these agents have a lot of benefit. Lead to about a 1% reduction in A1C. They are incredibly beneficial for patients with diabetes that also have chronic kidney disease or heart failure due to their diuresis effects and other beneficial effects. They have a low risk of hypoglycemia, and they promote weight loss. Some of the major downsides are these are newer agents, so they are very expensive. And because of its mechanism of action, this increase in glucose excretion increases the risk of mycotic genital infections as well as dehydration. And this class of agents have become a first-line option, especially for those individuals that either have a risk of or established renal or cardiovascular disease. Moving to the next slide. So now that we have covered all of these different agents, how are these agents selected and combined? So moving on to the last slide. And the greatest takeaway from this video is that we begin with a first-line agent. It might be metformin, it might be a GLP-1 receptor agonist, or it might be an SGLT2 inhibitor. And then the other agents are added if needed to provide additional blood glucose control of different mechanisms to try and target different components of this disease mechanism. And the selection of which agent to add will really depend on its pharmacologic profile and patient factors like presence of atherosclerotic disease, heart failure, chronic kidney disease, or their level of hypoglycemic awareness, their need to minimize weight gain, and of course cost. So this should be one of your biggest takeaways from this video, in addition to being able to understand each agent's mechanism of action.